Good day to all of you. I am here to narrate to you my ADL experience shared with my pediatrician colleagues as clinical faculty for ESMPH, the Medical School of Ateneo. Our team handles the interns. They are the medical school learners in their fifth and graduating year who rotate in the Department of Pediatrics for 2 months. The pediatric rotation covers the evaluation and management of pediatric patients in the hospital, the outpatient clinics, the nursery for newborn babies, and the emergency room. The exposure allows interns to encounter well children for primary health care and sick children for urgent and emergent care. As interns, the learners expect to be fully immersed in hospital work, functioning as general doctors in training. The biggest challenge posed by the pandemic to us is a shift from face-to-face patient encounter to an almost no patient encounter, plus the compelling circumstance that the interns are in their last year. This translates to their last chance for exposure in handling patients under supervision of the clinical faculty, their last chance to practice procedural skills like IV insertion, blood extraction, resuscitation, and newborn care, to name a few, before they get their medical licenses for professional practice. As an alternative to case exposure in the hospital, the faculty found ways to enhance case-based learning through ADL, where we presented normal growth and development patterns, common and acute illnesses, complex and uncommon illnesses, and common pediatric emergency conditions. Despite the successful transition to online learning, the clinical faculty shared one common doubt. Will our medical graduates practice competently when on the job, even if they fulfill the rubrics for evaluation that we designed? Personally, I thought if it is inevitable that their clinical astuteness will fall some notch below than if they had full hospital exposure, then this batch of young doctors should be edified in some other aspect of a healer. I decided that during online clinical case discussions, I will enhance their practice of good medicine. Good medicine starts with the intention of treating the patient and not the disease. It is about paying attention to all aspects of the child to identify the root cause of the illness so that treatment becomes more individualized, effective, and longer lasting. In my years as trainer of young doctors and working together with colleagues, the biomedical approach to health is the dominant approach when pathology is attributed solely to measurable somatic variables. The birth of epigenetics, a new branch of science that evolved steadily since 2005, validated how behaviors and environmental exposures change the way the body reads a DNA sequence, shedding light on the correlation between lifestyle and risk of disease. It is this perspective that I thought would enrich the medical expertise of our interns. Thorough small group discussions were used to roll this out. The long, physically laborious hours of hospital work were substituted with lengthy discussions on how to manage an illness, how to recover to a healthy state, or how to prevent illnesses, not just by understanding the body and its ailments, but by considering the person both in their ill-free and ill state. Going beyond the boundaries of the biomedical approach in getting to know our patients creates more physician-patient rapport as an inevitable benefit. In a way, it also enhanced discussions on public health because good medicine entails lifestyle modification as strategy for primary prevention, which is a public health domain. Sensitizing the interns to this holistic approach makes it more likely that root causes of illness are understood and more effective treatment is achieved. I know I made an impact when I get messages like these from the interns. Since we resumed face-to-face internship intermittently this year, I am confident that the ASMPH interns brought with them a significant amount of good medicine and practice. Thank you and a pleasant day to all of you.